A 33-year-old man, a bank employee, has been brought to your hospital. Upon returning from shopping, his wife found him unconscious at home and immediately called for an ambulance. After 30 minutes, the ambulance arrived at the hospital, and the emergency technician informs you about the patient's condition. The paramedic reports that the patient has been unwell for 3 days with flu-like symptoms and chest pain, which suddenly worsened today. The paramedic then presents you what they have done for the patient on the way back to hospital. They took vital signs. Blood pressure was 90/70 mm of mercury, pulse rate was 150 per minute, respiratory rate of 24 per minute, and no fever, and SpO2 of 100% with high flow nasal oxygen, and GCS was 40 from 50. Imagine you have confronted this patient in your hospital. What would you do in the next step? Please think and make your plan for any step before watching the rest of the video. It would be far more useful than just passive listening. Okay, let's delve into managing this case. The first step is to complete the patient scenario and ask some important questions that is not clear for us yet, like asking about past medical history and the medications he is taking. His wife tells us that his husband has had diabetes for about 10 years and his doctor has prescribed him 2 types of insulins, which she cannot remember the names. One is gray in color, taken once daily, and the other one is navy blue, taken 3 times daily. Probably the gray is Lantus or Glargine and the other one is Novamix. Now it is time to have our targeted physical examination. The patient appears kinda restless, pale, sweaty, and breathing rapidly and deeply, like he is hungry for air. This is how he is breathing. Please use headphone for better understanding. Do you know what is the name of this type of breathing? Yes, it is cosmal breathing. As you heard, the patient's breath is rapid and deep. This process happens when there is an acidosis in the body, and the body starts a process to get rid of these excess acids. This mechanism is called respiratory alkalosis, means the body increases the rate and depth of the breaths to excrete more carbon dioxide from the body, means excreting out more acids to keep acid-base balance in the body. There are some differential diagnoses for cosmal breathing. The most common is diabetic ketoacidosis or DKA, various types of cancers, alcohol consumption, sepsis, and liver and kidney failures. And other examinations were normal. Now it is time to make our differential diagnosis. Therefore, we can plan our targeted management for the patient. The first one is MI, or myocardial infarction, because the patient has chest pain and he is sweaty and pale. Second one is pulmonary embolism, pericarditis, hypoglycemia, diabetic ketoacidosis, because the patient has had diabetes, pneumothorax, alcohol abuse, brain stroke, left ventricle hypertrophy. Now it is time to order the diagnostic test to make the final diagnosis. Because we are suspicious of MI and other cardiac disorders, we should perform electrocardiogram to assess if there is any sign of acute coronary syndrome, cardiac enzymes, troponin, and creatinine phosphokinase, blood sugar, serum electrolytes, chest X-ray, urine ketone and urine analysis, and VBG or venous blood gas. Electrocardiogram shows sharp T wave in pericardial leads that can be a sign of hyperkalemia, but there are no other signs of cardiac issues. Cardiac enzymes level are both normal. Now the diagnosis of heart disorder is less likely. Random blood sugar is 324 mg per deciliter, that is elevated. Serum sodium is 137 mmol per liter, which is normal, while potassium is 5.8, that is higher than normal. Chest X-ray is completely normal. Urine ketone is highly positive. And finally, the result of VBG is shown here. As you can see, pH is 7.23, that is lower than 7.35, indicates acidosis. Bicarbonate is 12, indicative of metabolic acidosis in the body. Carbon dioxide pressure was 24 mm of mercury, and this is also lower than normal limit, suggesting there is also a respiratory alkalosis currently active in the body, but it cannot compensate the metabolic acidosis. Okay, now what is the final diagnosis? The random blood sugar is higher than 250, pH is lower than 7.3, urine ketone is severely high and more than 2+, and bicarbonate level is below 18. All of these are suggesting diabetic ketoacidosis. Our patient is struggling with a flu-like disease. Any inflammatory process makes the body release more insulin and in the same time increases insulin resistance. This mechanism put a diabetic person in a high risk of getting diabetic ketoacidosis. Prompt treatment is crucial, focusing on hydration and normalization of potassium, pH, and blood sugar levels. Initiate hydration with 1 to 1.5 liters of normal saline IV fluid within the first hour. After 1 hour, if the blood sodium level is in normal range or higher, the same dose will be repeated for the second hour, but this time with half saline IV fluid. After 2 hours, if the blood sodium level is lower than 135, the normal saline will begin again with dose of 250 to 500 ml per hour, based on the hydration degree in the patient, and if the sodium level is equal or higher than 135, the same dose goes with half saline IV fluid. Now it is time to adjust the insulin dose for the patient. If the potassium level was lower than 3.3 in any DKA patient, it is contraindicated to start insulin therapy. The potassium should be upper than 3.3 because insulin itself increases the intracellular potassium uptake that can lead to lower potassium level more, and it might be life-threatening. Therefore, in this patient, we are allowed to give insulin because the potassium level is 5.8. Now let's see what is the recommended type and dose of insulin. Intravenous insulin regular should be started for the patient with the dose of 0.1 units per kg bolus first, then 0.1 units per kg per hour infusion. For example, if the patient is 70 kg in weight, we must give him 7 units of insulin first, then another 7 units infusion for an hour. If the blood sugar level is not decreased by 50 to 70 mg per deciliter within the first hour, double the insulin dose. Once the blood sugar drops below 250, reduce the insulin dose by half. When it falls below 200, transition from intravenous to subcutaneous insulin administration is needed. Accurate monitoring of potassium and blood sugar levels, as well as titrating insulin doses, is vital and extremely important in the treatment of DKA. Our therapeutic plan or medication doses may need to be adjusted based on any change in these parameters. We keep this process for the patient until the DKA is resoluted. DKA resolution is defined as 1. Blood sugar lower than 200 mg per deciliter, 2. Bicarbonate level more than 15, and finally pH more than 7.3.